For your kind introduction. Thank you very much for inviting me to this wonderful venue and this great meeting. It's lovely to see such a large group of people coming, and I particularly like the combination of child and adult psychopharmacology. So it's good to see that emphasis in the one meeting, and of course that's quite appropriate for thinking about developmental phenotypes, and maybe now we're learning a lot more about the early onset and the origins of adult conditions, and their developmental origins in childhood. And ADHD is a very good example of a neurodevelopmental condition that begins in childhood, but now we know a lot about following up adult children with ADHD into adulthood and seeing persistence of symptoms and impairments and leading to adult mental health problems. So I'm going to focus on emotional instability and focus predominantly on ADHD as it presents and looks like in adults, and then make some links and thoughts about the relationship between ADHD, bipolar and borderline personality disorder, but particularly because the treatments are rather different for the three different conditions. And so it can become quite challenging to correctly make the diagnosis and correctly target treatments for people who present with symptoms that often overlap one with the other in the same patients. So emotional lability, there is quite a growing literature on this, and the terms that I've listed here all come from the literature, some of the literature I've been reading. So people are using different terminology to describe often very much the same. There may be some subtle differences between the constructs, but essentially they're talking about excessive emotional reactions, things like frequent mood changes, becoming irritable, volatile or changeable moods, having a hot temper. And the terms used are things like emotional lability, mood instability, emotional dysregulation, emotional impulsivity. A US term is deficient emotional self-regulation. So they all have slightly different sort of concepts behind them. It's good to think about it at a more descriptive level, and these are just descriptions of some of the mood problems children and adults with ADHD often present with. So Wender and Reimer did a lot of work developing their understanding of mood symptoms in ADHD, and they said you get mood fluctuations from day to day and within the day. Children are often on a short fuse, they have a low boiling point, and they react easily and persistently to everyday frustrations. In adults, he said, they often feel irritable. You get frequent outbursts of short duration. Patients experience affective lability, and these might be defined as shifts from normal mood to depression or mild excitement, but sort of rapidly throughout the day. So the characteristic is something to do with being highly volatile from one part of the day to the next, changing perhaps multiple times a day, 4 or 5 times a day. And so patients will often talk about having mood swings or a changeable mood from moment to moment throughout the day. And then I just want to stop and think a little bit about the diagnostic criteria as they're currently defined. So this is based predominantly on the DSM, but the criteria are rather similar between the DSM and the ICD. But essentially, we're thinking about ADHD on the one hand, borderline personality disorder, and bipolar disorder. And one thing that they all have in common is emotional instability. And during my talk, I'm going to go into some detail about the kind of how we know that emotional instability is an important part of ADHD, and not only personality disorder and bipolar disorder. So if we begin just by thinking about borderline personality disorder, actually there's a great deal in common between a personality disorder and the definition of ADHD. And in this first box here, you can see that they both have a child or adolescent onset. They're both really defined as being extreme on a sort of continuum of normal behaviour, but when that behaviour is extreme and causes impairment, that's kind of part of the definition for both conditions. They both have a chronic trait-like course, so essentially these are non-episodic disorders. They are that sort of grow and develop out of childhood. They're pervasive across situations, although you may adapt or be better adapted in one environment compared to another. Impulsivity is seen in both. You often would see impaired social relationships. And so on a great deal of these factors, there's not much difference, in a way, between ADHD and borderline. But there are some key differences, things we think of as specific to borderline. Frantic efforts to avoid real or imagined abandonment, identity disturbance, recurrent suicidal behaviour, chronic feelings of emptiness, or transient stress-related paranoid thoughts. These are not really thought of as really part of ADHD, but they are part of borderline. And so when you're trying to separate out the conditions, if you're thinking of ADHD, you'd probably be focusing predominantly on the inattentive symptoms of ADHD and the restless overactivity, which is part of ADHD. So we'll come back to that later. What about bipolar disorder? Well, the overlap here is more at the symptom level. When somebody has a mood disturbance in bipolar, they often then present with symptoms that can look like and can overlap with ADHD and borderline personality disorder. They can be overactive, there may be pressured speech, they're also likely to be impulsive, they're distractible, they have attention problems, and they may also have mood symptoms and depressive episodes. And depression is quite commonly seen in ADHD as well. And they both typically have sleep problems. People with ADHD often find it hard to get off to sleep. But on the other hand, people with bipolar feel they don't need sleep. So although they have sleep problems, they actually tend to look rather different in the two conditions. But I suppose the key difference between bipolar and ADHD has got to be the episodicity. I mean, bipolar is something which essentially comes and goes in episodes, and it's a change from what you're normally like. It's a change from the pre-morbid mental state. And so that's rather different from the trait-like problems you have with ADHD and personality disorder, which are trait problems that are kind of with you all the time. They're not fluctuating, they don't come in episodes, they don't come and go. They're much more chronic and sustained. So that probably is one of the key differences. But I suppose in bipolar, at least one imagines that these problems are predominantly there during a period when your mood is different from what it's normally like. And that could be problematic to think about because in ADHD we also do see mood symptoms, particularly emotional instability, but also things like chronic low self-esteem, poor self-confidence, and so you often see chronic dysthymic states in ADHD as well. So we'll come back to all of these things, but you can see there are ways of separating these things out, but also there's quite a lot of overlapping features that can make it difficult in certain types of patients. So the question I have is, what about emotional instability? To what extent can we consider emotional instability to be part of ADHD? And the main treatment issue is to consider the differential diagnosis of ADHD from other disorders, given that there are many overlapping symptoms and features. The recent history of emotional instability goes back to Russell Barkley, but in truth, the idea that emotional instability was part of ADHD was actually part of the early thinking about ADHD. And then as the DSM developed, they dropped the emotional instability component. But Russell Barkley followed up children with ADHD into adulthood, and he defined these two groups, a group where ADHD was persisting in adults and another group where the ADHD was no longer persisting, and then compared those two groups to controls. And he measured what he called emotional impulsiveness. And so what you see is that the group that still have ADHD as adults had many of these symptoms relating to emotionality. They were impatient, quick to anger, easily frustrated. They overreacted emotionally. They got easily excited. They lost their temper more quickly, and they got easily annoyed. And so the more ADHD you had, the more of these emotional symptoms you had. And he went on and did a further analysis using regression to say, well, if we take out the measures of core ADHD symptoms, inattention and hyperactivity, impulsivity, is there a main impact of emotional instability on real life, on real life? And he found that emotional instability had a major independent contribution to function at home, in your occupation, in your work life, in your educational life, in terms of criminal activity, in terms of driving and driving accidents, and financial outcomes. So in itself, it was a predictor of poor outcome. And at least he concluded that emotional impulsiveness is as much a component of ADHD as the two traditional dimensions of inattention and hyperactivity impulsivity. So we know that ADHD is characterized by two main syndromes. So when you go into the DSM or the ICD, you have these two sets of symptoms describing inattention on the one hand, hyperactivity, impulsivity on the other. They are correlated together. They often co-occur in the same people. And we know that that largely comes about through genetic influences, which are shared between the inattentive symptoms and the hyperactive impulsive symptoms. But the question is, where does emotional lability fit into this in ADHD? And so could we argue that emotional lability reflects a third dimension of psychopathology in adult ADHD? So one way of trying to think about this is to look and see, well, are there treatment effects? Do stimulants and atomoxetine, do they treat emotional instability as well as core ADHD symptoms? We can look at the case-control differences in more detail. We can look at the contribution to impairment. And we can also look more at the etiology and particularly thinking about shared genetic risk factors. So I'm just going to go through some of these things. It's good just to step back and think, okay, well, what is ADHD? As I said before, it's thought of to be an early onset neurodevelopmental condition, and it's defined as a persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning throughout development. And what is not ADHD? It's not just a behavioural problem. It's not solely a manifestation of being difficult, being oppositional, being hostile, or failing to understand things. There's a core neurodevelopmental deficit with inattention and hyperactivity, impulsivity. The prevalence in children is quite well established, and across the world it averages out at around 5%. So you will see very high diagnostic rates in some places, and I think there is a problem. There's been recent research showing that ADHD probably is overdiagnosed in some regions within the US. But actually, on the other hand, we know that in Europe, it's almost certainly underdiagnosed. And in the UK, in children, probably only around 1% of children are diagnosed, whereas we believe the prevalence is more in the region of 3 to 5%. And that problem becomes much more apparent when you go into adulthood, because we know that many less adults are diagnosed than meet even the severe criteria for ADHD. And this slide shows what happens when you follow up children with ADHD into adulthood. And this is the result of some meta-analytic work from Steve Ferrone. And it's showing here that around 2/3 of cases still have symptoms, still causing impairment by the age of 25. They also found actually a much lower rate met the full diagnostic criteria for ADHD. So using the current criteria as they're currently described, only 15% still met the full criteria, even though 2/3 were still impaired by ADHD symptoms. That sort of finding actually looked a little bit more different in Europe if your starting point were children who had what we call combined type ADHD. So these were more severe children diagnosed in Europe who were high in terms of both inattention and hyperactivity and impulsivity. And although this is our data from the UK, a Dutch group found almost exactly the same findings. And so when they were followed up to the age of 24, actually we found that 80% of them still met full criteria. So it was a much higher persistence rate. You can see that there's a change in the symptom profile, because the combined type group, now half of them, the main picture is one of inattention, and the hyperactive, impulsive symptoms have declined as you've grown older. But actually there still is a group who are high both on inattention and also hyperactivity and impulsivity. And in adults, this group in particular are likely to present also with emotional instability. So you'll often see this combined group having addiction problems, personality problems. You'll see them in forensic settings, as well as in the general community. The symptoms themselves are rather behavioural, and I'm not going to focus on these other than to say each one on their own could be explained by a number of different causes. And so maybe that's why people don't really like the criteria. They're very behavioural, if you like. But actually, as a group, they work quite well, and they are very predictive of a core diagnosis that responds very well to treatments. So we think it works well, even though they're perhaps not the best criteria one could come up with. But I'm not going to dwell on that point. And of course, it's not only having certain symptoms. The symptoms are pervasive. They start in childhood. They have this neurodevelopmental origin. And in particular, they have to have an impact either clinically or socially. So it's not only that you've got symptoms, but they're causing you a problem. And it's really only when it's causing a problem that we want to treat people for ADHD. And the other big point, of course, is that the symptoms should not be better explained by another condition. And perhaps this is an area where people kind of question, when I see these ADHD-like behaviours, could they be due to another condition? The DSM actually does recognise that there are features associated with the condition. It's very important to remember that the diagnostic criteria are really only there to classify cases. They don't really reflect the full description of the condition. And when you look more fully at the condition, you see a range of other problems. And the ones that the DSM specifically mentions includes things like developmental traits, language and social development, educational problems, cognitive deficits, and also emotional symptoms, low frustration tolerance, irritability, and mood lability. So what do we know about the treatment effects on emotional instability in ADHD? And I thought it'd be interesting for me to show you some of our recent data from a study we did in a prison. And so this is a prison we have in London for young men aged between 18 and 25 years old. And normally their sentences are in the region of 1 to 2 years, sometimes less. And we know from a recent publication that the average prevalence of ADHD within prison populations is around 25%. And that seems to be at different ages and also across the two genders, according to this meta-analysis. There was also only one published study of treatment of ADHD within a prison population, and this was conducted in Sweden. And it's a very small study. They only had 15 on methylphenidate and 15 on a placebo. But what you'll see is, at least in this one study, there was a very huge effect size. And effectively, that's because there wasn't any placebo effect in this particular study, which is very unusual. You nearly always get a placebo effect. But because of that, you ended up with a very large effect size of around 2, with a number to treat of 1.1. So I'm not expecting this necessarily to replicate, but it might be that these cases were particularly severe, and so therefore there wasn't much of a placebo effect. And maybe the prison environment meant that you couldn't adapt your environment in any useful way, and again, limiting the placebo effect. The other study that got a lot of prominence in the UK, there was a lot of publicity about this study. It was also based on epidemiology from Sweden. And they were looking at the number of criminal convictions in the population. So Sweden have these wonderful national databases, and they can link up medical records to criminal justice records and to other kinds of national records. So they were able to, first of all, show that the group in their country with ADHD, 36.6% of them would have had one or more criminal convictions in the previous 4 years, compared to only 8.9% of the group that didn't have ADHD. And this is a nationwide study, so it's a very large data set. And there's a similar ratio in women. What was most striking was then linking it to treatment databases. And they were able to show that during periods of treatment with ADHD medications, these criminal conviction rates went down. And when you came off your ADHD medications, criminal conviction rates went up again. And so here they're talking about methylphenidate and atomoxetine, and here are the effects just for stimulants and just for atomoxetine. And this is actually describing a 32% reduction in criminal activity during periods of treatment. Now this, of course, could just be it's not a controlled trial, and it could just be that when you're engaged in treatment, you're less likely to be doing bad things, doing criminal behavior. But what was interesting is they did the same analysis for an antidepressant, very commonly prescribed antidepressant, SSRIs, and there was no effect at all. So this effect was highly specific to the ADHD drug treatments. So at least it was very suggestive evidence that there was something really worth looking at in terms of treating ADHD in prisoners and the effect on behavior. So in our own study, we screened young men as they came into the prison. We screened a total of 1,922 men. And using our screening rating scale, we found that 25% were positive using a rating scale. And then we went in and we did careful diagnostic assessments using the DIVA interview. And I think Sandra Coy is giving a training on use of the DIVA interview later at this meeting. So I think people can go and be trained in the DIVA if they want to be. And having gone through that whole process and then done a careful diagnostic step, we ended up finding that just over 19% met full criteria for ADHD. So we offered those group treatment, and 40% of them came into treatment, and we treated 121 people. Now, it's an open trial, so I don't have any control data. So we have to be a bit cautious with how we interpret this. But what we're seeing here are really huge effects, first of all on ADHD symptoms, but also equally on emotional instability. And so we're talking about mood lability, emotional reactivity, and temper control. And these actually have I'll show you the effect sizes in a minute. Although this is an open trial, in fact, only 20% of this effect needs to be due to the drug for it to equal the same effect size coming from studies done in normal community populations with placebo-controlled designs. So we only need 20% of this effect to be due to the drug to kind of meet the effect size we're expecting from community controlled studies. We also saw improvements in behaviour. So there was a reduction in what we called critical incidents. And these were things like the number of serious assaults, fighting, property damage, harming yourself, taking drugs, and generally being disobedient to the level where a prison officer would record this on the prison records. And then also we actually see there's an increase in positive reports. And this is a scheme within the prison where if you're doing good things that are thought to be helpful to yourself, a kind of part of like engaging in rehabilitation, you get positive marks given to you by the prison officers. And so you can see there's an increase in positive behaviour as well as a decrease in negative behaviour. And so this finding here is rather exploratory and preliminary. But we were looking then to see, well, are there any predictors of improvement in behaviour? And the only one that was significant turned out to be emotional dysregulation. So the effect here is rather small, but nevertheless it was the only change in symptoms that explained the improvement in behaviour, and that was emotional dysregulation. So you can see in general we get very big effect sizes for symptoms, and including emotional dysregulation over here. And then you've got a measure of affective lability and a measure of machismo, which is kind of the way you would react in a situation where you might become aggressive, where you're provoked and you might react in an aggressive way. And people were then scoring themselves as less likely to react in an aggressive way in those situations. And the effect sizes are rather smaller for the more objective measures we have, taken straight out of the prison records. Okay, just a final point from this study was when you actually start looking more broadly at psychopathology, and so using a measure called the brief symptom inventory that measures a whole host of mental health symptoms, you actually see quite large improvements across a whole range of different domains. So less somatizing symptoms, less depression, less anxiety. So in general, there's a general improvement in psychopathology when you treat people for ADHD. Okay, so what were the main areas what do patients actually tell us? Well, they're better able to focus, their mind wanders less, and they can focus more on what they're doing. They become less restless, mentally and physically. They're better able to sleep. And their mood is more stable. And for many of these prisoners, mood instability is quite a big aspect of their problem. Being calmer, more in control, and more stable with their moods is a great improvement for them, and they greatly appreciate that. There was one last thing I wanted to mention from this study, was we also asked people about their drug use, and we were always intrigued to know why do people use drugs. And so we measured this. You can see that in UK prisons in London, young men do not use opiates at all. That's actually zero. So the drugs that people are using are basically cannabis, alcohol, and stimulants in the UK. And the two interesting ones that were significantly higher in ADHD prisoners compared to control prisoners without ADHD, was cannabis use and stimulants. And so you could imagine that there might be, part of the reason could be self-treatment. And so we're interested in the idea that people do use drugs to calm themselves down. And that may be particularly true for cannabis. And we know from, I suppose, rather anecdotal accounts that prisoners say, well, yes, when I smoke cannabis, I'm much calmer, I'm more relaxed. And some of them say they can focus and do more things. And so it is interesting that on a daily basis, we've got 71% of ADHD prisoners use cannabis daily in their real life, not in the prison, I hope, but only 30% of the group without ADHD. So there's quite a big difference in cannabis use in the ADHD group compared to the rest. So one of the things we're looking at are the effects of cannabis on ADHD symptoms and also mood instability, but we are still in the middle of doing those studies. So if we go back to the published data in the literature, a lot of the work in this field was developed by Wender and Reimer. And they always thought that mood instability was a big part of ADHD, and they had a measure, a scale of ADHD that included emotional dysregulation. And these were the items that they were measuring in their scale. Affective lability, temper control problems, and emotional overreactivity. And this is one of their studies, 2007, just looking at the effects of methylphenidate. And I suppose the key point here is that the effect size on emotion dysregulation is the same as the effect size on the core symptoms of ADHD, and then separately on inattention and hyperactivity and impulsivity. So it has the same effect size. That's the key point. They also showed in that study that the two types of symptoms co-varied with each other. So the correlation in the improvement in emotional dysregulation with the improvement in either inattention or hyperactivity impulsivity was over 80%. So essentially, as your ADHD symptoms got better, your mood became much more stable at the same time, and the two correlated at about 0.8. They also looked at atomoxetine. I already had a discussion about whether atomoxetine works in ADHD. But all the publications tell us that it does, and the average effect size is around 0.4 for adult ADHD. But in this study, you can see they equally have an effect on emotion dysregulation as on inattention and hyperactivity. Interestingly, although you can see here there's no effect on the Hamilton Depression Scale. So it does seem that these treatments are really helping emotional instability, but they're not really helping depression. And there's a difference between depression and having an unstable mood. Okay, so that's the evidence from the treatment, and there have been some other studies that show very similar types of results. I now wanted to talk about some of the case control differences we see. And this was work done by a PhD student who worked with me, Caroline Skiro. And part of the issue we had was, couldn't this mood instability just be due to the comorbidities? And people often say that 70 or 80% of people with ADHD have another problem. They've got anxiety or depression or personality disorder. So couldn't this be causing mood instability? So in order to try and get round that problem, we picked out the very small, relatively small number of patients who had ADHD but didn't have a comorbid disorder. And we had to work quite hard to get this sample. So we had 508 men, and then we removed from the sample people who were using drugs, even people who were being treated with medication, and then people who had a range of other mental health disorders. And we ended up with a final sample of 41. So this was an unusual sample, but they had ADHD, but they didn't have other types of, they didn't meet criteria for other mental health disorders. The first thing to note is they're very symptomatic. So even in this non-comorbid group of adults with ADHD, you do see a lot of symptoms compared to normal healthy controls. So they describe a lot of fatigue. Of course, they have concentration problems and forgetfulness, because that's part of ADHD. They have sleep problems, they get irritable, they worry about things, they describe depressive symptoms, and they have some avoidance behavior, a degree of anxiety-type symptoms as well, even though they're not meeting full criteria for these other conditions. We then just looked at some simple rating scales. So these were measures particularly of mood change, either swift change from normal mood to other emotional modalities like elation, depression, and anger. And then another scale which measured things like getting frustrated, getting angry, and getting upset. And essentially we showed, again, big case control differences. The group with ADHD had much more self-rated emotional lability. And in fact, if you do a ROC analysis, you can see that the sensitivity and specificity of these scales of emotional lability are very high. And in fact, they're almost as high as rating scales for inattention and hyperactivity and impulsivity. So at least it's a very strong predictor of ADHD versus a healthy control group. And then we wanted to know more about the specific character. What does mood instability look like in ADHD? And in order to measure that, we thought we'd use experience sampling, where people measure what they're feeling like at intervals throughout the day. So we asked people to wear a watch which vibrated at varying intervals. And in fact, 8 times a day they were asked to rate, how are you feeling on this rather old-fashioned looking PDA? And the questions we said is, are you feeling frustrated? How frustrated are you feeling? How angry are you feeling? How irritable? And also, how happy and excited are you feeling? And they rated themselves on a scale from 0 to 100, a sliding scale. And essentially, the data in anybody looks like this. I mean, it goes up and down throughout the day, and that happens with all of us. This is a rather technical slide, so I'll skip that one. If you want, this is what the data looks like. It's one way of representing the data. So each row is one person, and each little pixel is how they're feeling. And the darker it is, the more angry they're feeling in this particular slide. So you can see this is the ADHD group up here, and this is the controls down here. This person at the bottom, who's a healthy control, obviously was quite angry for a period of time, but then you can see most of the time their mood is quite stable. But overall, you can see the ADHD group are much darker, so they're more angry, and it's much more speckled, so it's much more changeable from one minute to the next. And if you analyse that, you can see that there's more irritability, frustration and anger in the ADHD group than the controls. This is not significant, so in fact they weren't more happy or excited. They were more irritable, frustrated and angry. And over here now we're looking at the variability, the changeability from one moment to the next. So they're much more changeable in terms of these mood states, and now these actually are significant. So they're changeable one moment to the next. And you can see that part of the problem is overreacting to a bad event. And so here we have something bad has happened, and this is the control group, and there's very little emotional reaction. They're very well controlled, and they're not overreacting to this bad event. Whereas the ADHD group, and again I think this is of anger. Anger. You can see they're becoming much more angry, and then it takes them about 2 hours for that to come back down to normal again. So in a way, that's what the emotional instability looks like in ADHD. We think that in addition to this, there is an endogenous, an inherent instability as well as this overreacting to events. And that's something we're still looking at. So I'll touch very briefly. So that tells us something about what the mood instability looks like in ADHD. I just wanted to touch briefly on the genetics. And genetics is quite a big area in ADHD because we know the heritability is about 80%. And there's a lot of work currently going into looking for the genes for ADHD. This is a slide you may have seen. It's a famous slide where they estimated the amount of the heritability explained by measured molecular genetic SNP maps across the major psychiatric disorders. And you can see ADHD here, the SNPs are measuring about 28% of heritability. And actually very similar, and in fact slightly more than bipolar disorder, schizophrenia. This is major depression and this is autism. So in a way they're rather similar in terms of the genetic effects that are being picked up by common genetic variation. And in our own work, we were looking at twin studies and saying, well, what is the degree to which there are shared gene effects on ADHD symptoms and emotional instability? And we first of all did this in a sample of children, and then later on in a sample of young adults, aged 19 to 20. And in the children, these were parent ratings. We had the Conners scale, And there are just 3 items: temper outbursts, explosive, unpredictable behaviour, crying often and easily, and mood changing quickly and drastically. And in fact, that as a phenotype is quite heritable. It's about 50% in the younger children, and it goes up to something like 70% in the older children. And here we're just looking at the phenotypic relationships between hyperactivity, inattention, and emotional lability. And the key point here is that emotional lability actually shows quite a strong correlation both with inattention and also with hyperactivity and impulsivity. And in fact, there's not much. It is slightly higher for hyperactivity and inattention, but actually they're all rather similar. This is the weakest one. Emotional lability relates most to hyperactivity and somewhat less to inattention in children. And if you then do if you do a genetic model analysis, what it essentially tells us is that there's a common set of genes here which explain a large part of the variance in hyperactivity, inattention, and emotional lability. It's just telling us there's a lot of genes in common that influence the risk of you developing each of these 3 sets of symptoms, if you like. And then we did a very similar analysis in the older children. We had a different scale. This was from the CBCL. And so you've got attention problems, which is rather similar to ADHD. Mood lability and emotional instability was actually mingled in with other measures which are sort of more to do with being oppositional and difficult, and was called an aggression scale. And then we have another scale down here called anxious and depressed. The reason why we picked these 3 is because this was the scale that Joseph Biederman used to define juvenile bipolar disorder. He said if you were high on each of these 3 scales, you had juvenile bipolar disorder. And you may know that became very controversial, and many Europeans felt that, no, these are children with mood dysregulation problems. That doesn't mean they've got bipolar disorder, not typical bipolar disorder as we would think of manic depression or bipolar 1, for example. And of course, these traits are found throughout the population. And again, rather similar to the findings in children, we see very similar correlations between inattention, hyperactivity, and the aggression emotional lability scale. And then when we do the genetic analysis, again, we find there's this common set of genes which has a major effect on inattention, hyperactivity, and aggression. And you can see here a somewhat smaller, but also an effect on these anxiety depression measures. Okay, so that's really telling us something about ADHD and emotional instability. Emotional lability is a common feature of ADHD in adults, not just in children. It's often seen, it can be seen in non-comorbid adults, but diagnostically it becomes more tricky if somebody has a personality disorder or bipolar disorder. It is a unique source of impairment, and it does importantly respond to the ADHD drug treatments if the person has ADHD. And so atomoxetine, methylphenidate, and dexamphetamine. And you can see that there's some shared etiology at the genetic level. But the big problem is that emotional lability is not very specific to ADHD. And I thought this was a very nice study that really demonstrated that. And this was from Ebner Primer's group in Germany. And they again used this experience sampling method, but here they used it in a different way. You rated yourself every 15 minutes during a typical 24 hours. And it's the same idea that the more red, the more symptoms you have, and then up the green end, the less symptoms you have. And here it's actually quite a complex measure they called valence, but it's essentially measuring the degree to which they're feeling emotions, how angry, irritable, excited they're feeling. And this is a measure of the distress that they rate linked to that feeling. And so here, this is a group of people with borderline personality disorder. So not surprisingly, compared to controls, they have very high valence for these mood symptoms, and they're much more distressed by these mood symptoms. So this is really what you'd expect for borderline personality disorder. So when we think of borderline, we think of emotional instability as the core feature defining that condition. But what happens when we look at other conditions? And so now this is another condition, post-traumatic stress disorder. So these people don't have borderline, they do have post-traumatic stress, but you really can't see any difference in the degree to which they're experiencing these emotional shifts and changes throughout the day, and also in terms of the amount of distress linked to that. So, I mean, if you had no idea, you'd think they were both in the same clinical group. And then they have a third one, which is bulimia nervosa. So we have a sample of people with the bulimia nervosa. To my eye, again, it looks very similar. And in their analysis, they couldn't find any difference between these three groups in terms of the amount of emotional instability or the amount of distress. And of course, all of these groups are very different from controls. So it does tell us what I think is well established. Emotional stability is not terribly specific to one condition or another. On the other hand, the treatments for emotional instability may have some specificity. And so it could be that, of course, there may be different causes for that emotional instability in different people. So I don't know whether that means emotional stability is like a fever that could have several different causes, and you have to find out the correct cause to find the right treatment. But it obviously is a very important area for further research to fully understand and unravel these questions. So this is, I won't go back over the criteria for personality disorder, but when you're trying to think through, I think it's harder to separate out ADHD from borderline because they both have the characteristic of being trait-like problems. So ADHD symptoms will look a lot like a personality disorder. You know, they're problems with your temperament. Whereas bipolar should be easier to separate out because it's inherently something that is episodic and different from what you're normally like. You should be experiencing episodes. And so this is really a tricky area because there is so much in common between ADHD and personality disorder, and one might have to focus down on the specific features of ADHD and also the specific features of borderline to try and make these separations properly. And when we think about bipolar disorder, we know that it's this episodic condition. You have manic episodes, you have depressed episodes. But it could be that even when you're euthymic, there's a degree of emotional instability in between your episodes. And in fact, this work from Guy Goodwin's group was suggesting that there might be two types of bipolar, if you like. A group that have mood instability when they're euthymic, and another group here who are much more stable when they're euthymic. And so we did a small study just comparing ADHD with bipolar disorder. And so we're comparing ADHD. Now, these are bipolar 1 patients who are euthymic. It's in between their episodes. And I'll go through these on separate slides, but these are ADHD symptoms. These are mania symptoms, and this is affective lability. And if we just measure affective lability, that's not very good at separating out ADHD from bipolar, so we're not very surprised at that. Again, these are bipolar patients who are euthymic in between their episodes. But you can see the ADHD group has slightly more affective lability on these two scales than the bipolar group. But I didn't put significance values on these slides. I only did this very recently. But these are not significantly different from each other, but they are from controls. And then you can look at the mania symptoms, and it turns out mania symptom scales are also not very specific. And so on these mania scales, the euthymic patients with bipolar seem to have very similar scores to the ADHD group. It only really differs when you ask them about the past episode. So if you take the mania scales and you ask them to rate what they were like during a bipolar episode, of course, then they do have more manic symptoms. But in between episodes, you can see that they're actually coming out rather similar on mania scales. Depression really doesn't help you very much either. The ADHD group are somewhat more depressed than bipolar patients who are not in a depressive episode. So in general, you get more symptoms in ADHD than you do in between episodes in bipolar disorder. But what I thought was quite helpful is that, in fact, the ADHD items actually are quite good at telling you you've got ADHD and you don't have bipolar disorder. And these are just using the rating scales, and here we're using the full DIVA, the diagnostic interview. And particularly with the diagnostic interview, you can see the ADHD group has much higher scores than either the bipolar or the control group. So actually, ADHD symptom scales are really quite good at telling you you've got ADHD and you don't have bipolar. And if you do a ROC analysis comparing the ability to pick up ADHD compared to bipolar, it's actually very good indeed. So it won't help you if you've got somebody in the middle of a manic episode. And the tricky patients could be people who have hypermania of a mild degree, and that could look very similar to ADHD. But you'd really be trying to characterize the fact that it's a change from what they're normally like, whereas in ADHD, they're like it all the time, and they have been from a very young age. So, to kind of conclude and bring things to conclusion, it's just good to reflect on how we'd translate this into the clinic. And this is what Eric Taylor said you should do in children, and I think a similar idea might work in adults as well. So essentially, the first thing you want to make sure is you're not talking about normal behaviour, but it could be in keeping with the developmental stage. So if somebody, particularly if somebody has a lower IQ, and depending on psychosocial stress, you do need to think about whether this is a normal emotional reaction you're looking at or not. But having excluded that, you then also need to think, well, it could be ADHD, but there is a bunch of other conditions as well that could also lead to emotional instability. So you need to check for things like autism, drug and alcohol abuse, anxiety, depression, and so on. In adults, it's really very similar. But if somebody is presenting with a chronic form of emotional lability, ADHD ought to be on your differential diagnostic checklist, along with probably a personality disorder and or other sort of chronic trait-like conditions. But that's really the main feature. And then you could say, okay, you'd screen for ADHD. If you think they have it, you need to do a careful diagnostic interview, because that's quite good at separating out ADHD from other conditions. So if they don't have ADHD, you can go on and treat the primary condition. If they do have ADHD, you need to decide whether or not they have another condition. So it may just be ADHD with mood instability, and the mood instability can sometimes be quite severe. So at least that is one possibility, and in that case you would treat ADHD. But the ADHD could also be accompanied by other disorders, and particularly if they're presenting with a depressive episode or they have comorbid bipolar disorder and they're in the middle of an episode, it would be very important to treat that first and then reassess them once their episode had resolved. But once you'd reached a stable state for that individual, you can then go back and reassess ADHD. And I think if it's comorbid with a personality disorder, you really ought to treat the ADHD, because it could have a big impact on their mood instability, their ability to engage in any other kind of treatment, and including psychotherapy. The one thing to say is there's not a lot of research in this area, so I'm very pleased to see that some people in Turkey have targeted this as an important area for research, and I think it undoubtedly is. And so I'm going to end with a final comment, just to think about the DSM classification. We do always need to remember that it's designed to categorize patients, and so clinically it's useful, because it gives you an idea about what treatments to target at what people. But scientifically, most of these categories lack any kind of validity. And you do have these transdiagnostic constructs, and emotional instability is certainly one of those, that it looks very similar across a range of conditions. And so we need to do more research and be a little bit clearer about, you know, how we treat instability within different contexts. And one should certainly include ADHD as an important part of treatment when you're thinking about mood instability in adults as well as in children. So thank you very much, and thanks to various of my closest collaborators. Thank you.